So this question is from 2023 question paper of medical science optional from general surgery, and the topic of focus is lower limb arterial ischemia. So in the syllabus we have a topic that is peripheral vascular disease. In that they're asking questions from both arterial disorders and also varicose wounds or venous disorders. So this question is from arterial disorders, that is PVD, peripheral vascular disease. Now in arterial diseases we have acute or chronic arterial ischemia. So acute cases are mainly because of embolism, and chronic cases which are more common are because of atherosclerosis. Now in the first part of the question they are just asking you enumerate the signs of lower limb ischemia. Now they are asking you signs. So clinical features includes both signs and symptoms. So symptoms and signs. So the symptoms usually which we see, the features of chronic limb ischemia are intermittent claudication, rest pain, sometimes patient you see ulceration and gangrene. So they present with these features. So they're not asking you what are the features. More importantly, from exam point of view, they're asking what are the 6 P's. So 6 P's of acute limb ischemia. Just note a point, I'm saying acute limb ischemia. Only in acute cases, some of the times, not every time, you will see one out of many of these features, that is 6 P's. You will see pallor of the limb, you will see pain, you will see paresthesias, pulselessness, which is a very late sign, you will see paralysis and poikilothermia, that is cold to touch. So these are the 6 P's that they are asking you. Enumerate the signs of lower limb arterial ischemia. Now, because of ischemia, you see these 6 P's in acute cases. What happens in chronic cases? Let's differentiate. You have acute ischemic foot and you also have chronic ischemic foot, right? So in acute cases, what you see is, yes, they are cold, but in chronic cases, because of the collateral supply, they are warm to touch. This is one differentiating factor. The second thing is, as I told you, poikilothermia, they're cold and they're also pallor, that is pallor, white in touch, okay, white in appearance. Whereas chronic ischemia, because of the collateral supply, they are red and swollen. Okay, red and swollen. This is the major difference. Next is there will be loss of sensations, paresthesias, which later leads to loss of sensations, but here sensations are intact in chronic ischemic foot. And paralysis, which is commonly seen in acute ischemic site, is very rarely seen, so there is no paralysis. So the 6 P's what we see are actually specific for acute ischemic foot, which is caused by embolism. In chronic cases, you will not see these 6 P's. You will see warm, red, swollen, sensations are present, no paralysis. Okay, so this differentiation you have to mention for 5-mark question here. So the next question is 6.B.2. Briefly outline diagnostic workup in a 62. So what is the case here? It is 62-year-old, okay, is a male patient, okay, presented with atherosclerosis of the lower limb, okay. So just this is the basic point which they give, that is there is atherosclerosis in the lower limb. So what is your diagnostic workup in this case? So when you want to do some diagnostic workup in this cases, you have to go for 3 important things. You have to examine, you have to do general investigations, and you have to do special investigations, right? So they are asking you diagnostic workup. It's very important that these kind of questions you follow a algorithmic approach. So in the examination, most importantly, whenever we see a case of peripheral arterial disease, we check for capillary refill time. Okay, we check for capillary refill time, not getting into the details, and because in the regular video I did discuss all these things in detail. And we also check for arterial pulses, Okay, we check for arterial pulses, and we also look for bruit for arterial bruit. Okay, we check for broods. So these are the briefly examination findings. Even if you do not mention, it's fine, examination, because I could see some of the toppers in their papers, they are writing examination, physical examination points, then they're getting into investigations. So for me, more important is for surgery questions, you need to write general investigations which are done for surgical fitness, and also you have to look at the special investigations. So now let's try to look at the general investigations. General investigations, what we do in general, we go for CBP, because sometimes even polycythemia can cause acute ischemia. Very importantly, we do RBS, because many of the times patients who are prone for atherosclerosis, we have to rule out the diabetic status. Okay, they are also diabetic, they might develop later wet gangrene because of the clostridium infection, right? So RBS should be done. And renal function test, that is serum creatinine and blood urea, are very important for two cases, because atherosclerosis of lower limb might also affect kidney, leading to renal artery stenosis. And second thing is, one of the special investigation what we perform in these cases, one of the special investigations what we do in these cases is iotography. Okay, iotography, wherein we inject contrast. So whenever we do contrast medium, we check for serum creatinine and blood urea levels in these cases. So, because contrast induced nephropathy can be a future complication. We have to do also the lipid profile checking, because atherosclerosis we have to see the lipid profile status, because we also give statins in these cases. Very importantly, the same atherosclerosis can also affect the heart, coronary arteries, leading to myocardial infarction, and also the brain, leading to the stroke. So we have to check for the ECG and 2D echo status. We have to do ABG and PFT to check for the surgical fitness states, to see, because concurrently these males, they might also be smokers, because smoking is a risk factor for atherosclerosis. We have to check for the lung status, whether the lungs are fit enough to undergo for surgery. And finally, we also need to do for X-ray food to look for gangrenous changes. So these are the general investigations, and also tests for surgical fitness which are commonly done. If in case, if the patient is developing gangrene, if you're going for amputation, or if in case there is a blockage in multiple segments of the arteries, if you're going for bypass surgery, or transluminal stenting, which are management options, I think you need general investigations to be done. And next important thing is, very importantly, what we do is special investigations in these cases. And special investigations, what we usually do is ultrasound. Yes, this is what we regularly write, handheld Doppler ultrasound of both lower limbs. Okay, followed by duplex scan. Okay, the difference is, any problem can easily identified by ultrasound, but localization of the site of lesion, so localization is can be better done by duplex scan. Localization of stenosis can be easily done with the help of this. So in special investigations, we do ultrasound or duplex scan, and very importantly, we also check for ankle break pressure index, which helps in management. In ankle pressure break index, if the value is less than 0.93, it indicates imminent necrosis. That means you have to go for definitive management. In these cases, you can't wait. If it shows claudication or wrist pain, you can wait, but imminent necrosis indicates immediate management in these cases. So these are the investigations which we do. But sometimes what happens, if you do duplex scanning, the problem with duplex scanning is, you cannot, it is difficult to look at iliac segments. See, because lower limb ischemia can be starting from aorta, okay, in aorta iliac junction, then the iliac, common iliac, femoral, popliteal. So this junction cannot be better visualized in obese patients with the help of duplex scan. Peripheral limb can be visualized, but central aorta cannot be visualized. So in those cases wherein you are suspecting aorta iliac segment involvement, we have two options. The older one, which is invasive, is digital subtraction angiography, which is gold standard, which also helps in therapeutic management. The latest one are CT or MR angiography, but the picture quality is little poor in these cases. So these are all the special investigation options which are available in these cases. Now you have investigated this case. So the case which we are discussing here is a 63-year-old male with atherosclerosis of lower limb. That's it. Now what to do? If the patient has deteriorating ABPI, or if the patient is having rest pain, okay, or if the patient is having critical ischemia in ABPI, in whatever it case, if the patient is progressing to more critical stage, then you have to go for the treatment. Okay, if not, supportive treatment is more than enough. Supportive treatment, right? We have to modify the risk factors. There are multiple risk factors like treat hypertension, treat diabetes, avoid cessation of smoking, give statins, okay, also give antiplatelet therapy in these cases. Antiplatelet therapies is given in these cases, and regular exercise as well. So these are more than enough, and serial follow-up with ABPA is done. If ABPA is deteriorating, if the patient from claudication is developing into rest pain, if there is critical ischemia noted, then we have to go to treatment. So what treatment options you have? You have multiple treatment options. You have endoluminal stenting. Endoluminal stenting can be done. If it is unsuccessful, you can go for, okay, you can go for bypass surgery. Okay, bypass surgery with the help of graft. But even after doing these two, if the patient is progressing to gangrene, then we have to go for amputations. So amputations can be distal or it can be whole limb amputation. So these are the treatment options which are available. So transluminal angioplasty is helpful in most of the cases, but problem is below knee it is not successful. So below knee, most of the times, if the lesion is below knee, better to go for bypass grafting. For the below knee cases. In patients with very severe symptoms, even after stenting or below knee, better to go for bypass or grafting. Now on top of that, if there is a pus, you have to drain it. We have to put the patient on antibiotics, and also we have to put the patient on heparin, and we have to give post-surgical follow-up in these cases. So this is how you manage a 63-year-old male presenting with atherosclerosis. So the question here is about what are the signs of lower limb arterial ischemia, what is the diagnostic workup, and what is the management in this case.